Hi, I'm tasked to lecture about communicating with patients and families about palliative care. I have nothing to disclose. My learning objectives are as follows: to explain communication as an essential competency in palliative care, to identify prominent barriers and myths to effective communication, to describe primary factors that influence communication in the care of older adults, list older adults and family expectations in communication with the nurse and interdisciplinary team. And lastly, to illuminate effective palliative care communication interventions and guidelines in providing care for older adults and their families. So, according to the NCP guidelines, so there's a need for effective communication. So, why is it important to communicate with our patients? So, communication is the most important component of our work. Okay, it is the cornerstone of our interaction with the people and their families, and a good and effective exchange between people helps them see what the other person thinks or how he or she feels. No, so it imparts essential information and support. So it requires interdisciplinary communication and collaboration that addresses all quality of life domains such as your physical, psychological, spiritual, and social ethic, as well as ethical and legal concerns and care at the end of life, no? And good communication of a dying person's prognosis improves the end of life and the bereavement experience of those important to them, and it can help to ensure that the dying person's expressed wishes are considered, and to avoid any misunderstandings and unnecessary distress for the family. So, what are our communication barriers? What stops us from discussing or communicating to our patients efficiently? So, when there's fear of one's own mortality, no discussing death or even saying death or dying, there's lack of experience, right? So, we fear when we express our emotions, and when we don't know what to say, we're having a hard time verbalizing. When some providers are insensitive, when there's a guilt feeling for failure, because sometimes or more often than not, the doctors think that death is failure, but it's not. No, it's part of life that we all need to agree and understand. And there's also um, communication barriers when we care for older adults who are cognitively impaired. Okay, we don't understand really what are they trying to convey to us, and also the desire to foster hope and many more, rather than to be honest and be open to what's really happening, and we just want to just give hope to them. Those would be some form of communication barriers. There's also fear of not knowing, or fear of the unknown, of fear of not knowing what to do, right? There's also some disagreements with decisions, both with the medical team or with the family member. There's also lack of understanding when the goals of care are not clear, or there's some cultural norms that are not coinciding with the plan of care, no? And of course, communication norms of provider relationships. When you haven't established a good rapport, it might create some form of barrier as well. If there are also personal grief issues that you cannot bracket and cannot disclose with your patients and their families, that can also be a source of communication barrier. and as well as ethical concerns, and many more. So, myths about communication, no? So, communication is not as simple as putting words together or stringing them together. And um, because when you want to convey your message, it's your responsibility as the physician to bring words to life for your patient to understand the meaning. And it's never deliberate. And of course, whatever you're saying is not always the same as a receiver would understand, no? And it's never primary, as well as it's never one way. It has to be a two-way. And of course, you can give as much information as you want to. In terms of verbal and non-verbal communication, 80% of communicating is about non-verbal examples, such as your body language, your eye contact, um, your gestures, and of course, the tone of voice. And verbal examples would be when you solicit information or explanations, when you validate, and when you encourage. That is according to Wittenberg Lels of 2013. So, what are the factors influencing communication? So, there's the family system changes, there's financial uncertainties, there's educational and learning capacity, there's physical limitation, as well as cultural considerations. So, how do we communicate with patients with dementia and older adults? We want to make sure that the environment is quiet because of their hearing disabilities. You have to be in a respectful tone and voice. We have to respond to their emotions rather than the words, and always be positive when we talk to them. And we have to establish a rapport before going into meetings with their families. So, in communicating with older adults or family expectations, there has to be really some form of respect. Okay, they want honesty. We have to elicit values and goals and honor them because of their experience. We have to have realistic options. We have to have team communications. We have to discuss with the rest of the family members and the rest of the attending doctors. And we have to listen. The most important thing is listening and unconditional acceptance. So, how we overcome barriers and have effective communication strategies? First, we have to identify the personal barriers and remediate. So, it's a skill that we need to practice. We have to identify where we are, where we need to improve on. We have to recognize and support individuality and personhood. No, we're not all the same, but we have our own set of skills, and it's just a matter of time that we need to improve on them. And we have to understand and support expectations as well, because through time we learn and apply new skills for us to be able to deliver what we want. So, what are the communication guidelines for sensitive talks? Sensitive talks mean that when you're about to disclose a prognosis or you want to break a bad news, so you have to find the right time and the right atmosphere. We just don't discuss or disclose things in the corridor or a place where people would pass by and may hear some very important or private matters. And we have to explore the readiness of the family member or the patient for readiness by asking if they're ready to talk about the prognosis of the or the very important thing that you want to discuss with them. And use open-ended questions and other techniques to encourage communication, because if you want to ask questions that would be answerable by yes or no, then the conversation would stop there. You want to probe more to elicit the feelings and for you to be able to address that as well, and the emotions and the misperceptions. So it has to be an open-ended question, not answerable by yes or no. Otherwise, there's no point in discussing further, because it has already uh, an answer to the question. No? So no more probing of the emotions and other eliciting misperceptions. Then we also have to be mindful of ethical considerations, because in discussing end of life, especially end of life or pain management, most of our patients would really have some researches about these things already, or they have some preferences. So we always ask them what is their preference rather than us dictating um, what should be done. So, what are examples of attentive listening skills? No? What do you have to do? Your conversation should be encouraging. You have to listen more than talk more. And when listening, you can validate the feelings. You have to give time um, to, to give advice after listening. And then you encourage by reminiscing and sharing stories. So, what you don't do when you're actively listening is when you change the subject, right? When you anticipate, or you interrupt, or you assume. So, those things we don't do when. The next would be mindful presence. So, non verbally present while being attentive is very important. And in the moment, when you start being non judgmental for whatever your patient or the family is trying to convey, by being silent, it helps them also acknowledge that you are listening to them. And then numerous components, no, knowing oneself, knowing the older adult, you foster meaningful connections by agreeing, nodding by nonverbal gestures, affirmation, valuing and intuition and empathy. So when facilitating family meetings, the attendees would be the following. So the older adult is always invited and encouraged to attend. We gather the whole family, the rest of the family members, and the most appropriate attending should be present. We have to discuss the purpose and the goal of the meeting, okay? And we have to use effective communication strategies, as I've mentioned a while ago. So, when breaking the bad news, we have to consider all the barriers that were mentioned in the previous slides. So, with an evidence based protocol, we use the spikies. We start with the setting, and you have to have the set of listening skills. For P, we want to know the patient's perception of his condition, of the gravity, the seriousness, no? And we want to invite um, the patient if we're ready to if we're ready to give the information, and they want to know, no, in giving medical facts. We want to explore the emotions and empathize with the patient as they respond to your breaking the bad news. And lastly, we have to summarize and strategize for the care plan of your patients for their next visit or for the next family meeting, when you want to disclose the prognosis. and the rest of the plans for the family. So we'd like to initiate and engage in end of life discussions using words such as death and dying. We want to maintain hope, and of course, we want to clarify the benefits and burdens of discussing end of life, well, the care plans for the patient, no? And this information sharing is necessary not only among you and your patients, but as well as the rest of the attending the interdisciplinary team members. Again, I'd like to reiterate the ethical considerations of discussing end of life. Since these are very sensitive matters, then we have to be very mindful and be very careful on discussing prognosis and care plans for your patients. So what are the 5 important messages that we want to give to the dying that you'll never go wrong? We want to tell them that we love them. We want to tell them that you forgive them, or you ask for forgiveness by saying, "Please forgive me." You say thank you and goodbye. So these are evidence-based messages that um, you want to give to the dying by saying, "I love you, I forgive you, please forgive me, thank you, and goodbye." So team communication is very important. It has to be consistent with the family members. You have to have one goal, and it has to be also in consider. You have to take consideration of the rest of the team members attending doctors has to have the same goal. You expect some form of conflict because of differences in ideas, but you have to address that as well during the meetings. Then you have to also take into consideration different expertise or different disciplines in the interdisciplinary team would really have some form of um, inconsistencies. So the reason why we have to communicate is for us to stick to one goal. And you have to do your SBAR, and the interdisciplinary team training is key. That you have to be a team player, you have to be open to what the rest of the doctors would discuss, and at the end of the day, we are patient centered. We have to have one goal, and it's for the patient's best interest. So when we resolve conflict because of the differences in ideas in a meeting, we want to take a step back, no? We want to be objective, so you identify your own emotions when there are people in the team that are too strong or too vulgar about their way of communicating. Then we have to define the conflict. At the end of the day, we want to reach a goal in agreement, and we have to look into the differences regarding the conflicts. We have to talk about it to your trusted colleagues, and again, it has to be the best interest for the patient, and that is the goal of the meeting. It has to be patient centered and for the best interest of the patient. So to summarize, we know that communication is complex, but it is a necessity. So it requires insight to personal behaviors. It's case to case. Not everybody has the same set of skills. So it necessitates the use of effective communication skills, like I've mentioned in my previous slides, and as well as our advocacy to help you build the skills. So the goal, at the end of the day, our goal is clear communications among the interdisciplinary team with the rest of your members, okay, especially for our patients who are older and the family members. It requires continuous quality assessment to assure good communication outcomes. So the reason for us to give you short trainings about this is for us to build the communication skills that we want in dealing with our patients, their families, as well as the multidisciplinary team.